Good evening. Welcome to the first forum of the Millennial Policy Center. So excited to have you all here, especially as we gear up for a big fight, however your perspective is, over healthcare and how we are going to direct our healthcare system in this country. And our goal at the Millennial Policy Center is to participate in revitalizing healthcare in America. To talk tonight, in particular, about repealing and replacing Obamacare, how that can be done, what that might look like, and what the benefits would be, and what it should look like. We've got a lot that we're going to be discussing this evening, so I welcome you all. Thank you so much for joining us here at the Millennial Policy Center's Revitalizing Healthcare in America Forum. Appreciate you joining us. So I am Jimmy Sangenberger, president and founder of the Millennial Policy Center program of the Liberty Day Institute. The Liberty Day Institute is a 501c3 nonprofit organization. It's all about educating the next generations on the basics of our country and how our country functions. We do a 5th grade program in the classroom, talking to kids about the Constitution, and then we do now our Millennial Policy Center program, which is all about engaging millennials, those who are currently between the ages of 18 and 35 or 36, and engaging them in the process of developing policy and being a voice for solutions to the problems that our nation faces. Very excited to be focusing right now this month on healthcare. As you may know, it's a small issue that's being discussed by 1 or 2 people in Washington, D.C. Nothing very common, nothing to watch, but we're going to talk about it anyway, despite that. And we've assembled a really great team of policy fellows here at the center that I am so excited to introduce for our forum. What we are doing today is discussing the issues of the healthcare topic, how to repeal and replace Obamacare, what that might look like, so on and so forth. We are also going to be publishing later tonight, after this kickoff event, our very first paper entitled Revitalizing Healthcare in America, and looking forward to sharing that with you all. So without further ado, I want to go to introducing our panel, and we'll go from the end over there on up closer to me. And that will be starting with Juliana Darrow. She is just one of our excellent members of this team. I'm very excited. She's a fellow in healthcare reform at the Millennial Policy Center. Very recently, she was with the American Action Forum and has worked in a number of different capacities. For example, she worked in health policy, has worked in health policy in Washington, D.C., analyzing and researching current healthcare priorities and legislation, having graduated from the University of Colorado with a degree in integrative physiology and with her master's in public health from the Colorado School of Public Health. So she definitely understands public health. Prior to moving to D.C., she worked at the HIV clinic at the Children's Hospital here in Denver, and she is very much passionate about how you can incorporate free market principles into solving the issues of healthcare. And we're very excited to have Juliana as part of our team. Then we've got Dr. Michael Parra. He's an MD. He, for 25 years, ran a practice, or 25 years or so, ran a practice that was studying, working on oncology services for folks, and sold that practice in 2012. He graduated from the Creighton University School of Medicine in 1984, attended the University of Colorado Health Sciences Center, and practiced medicine in Colorado for over 20 years in the specialties of hematology and oncology, as I noted. And during his time in practice, he served as an assistant clinical professor of medicine at the University of Colorado Health Sciences Center, section chief of oncology at Swedish Hospital, and vice chairman of medicine at Skyridge Medical Center. And I could go on, but I think you get the point that Dr. Parra has some really great credentials, and we're so excited to have him as a part of our team. And last but not least, Charlie Katibi is a fellow in healthcare reform here at the Millennial Policy Center as well. Prior to joining us here at MPC, he was also with the Wyoming Liberty Group. He's worked with the Reason Foundation, the American Action Forum, the Beacon Hill Institute, and others. He's also a contributing writer regularly to the Washington Examiner. So I'm just so thrilled and would like you to join me in welcoming our crew from the Healthcare Policy Group, Juliana Darrow, Charlie Katibi, and Dr. Michael Parra. very excited, and I won't go on about myself except to say that I'm just glad to be here and glad to have all of you as a part of this. We've got a great team, not just in healthcare, but in a number of other areas, and I'm just excited to see what the Millennial Policy Center will bring moving forward. So without further ado, let's get this discussion started. What we're going to do is have a panel discussion with our 3 healthcare fellows, and we're going to talk a little bit about some of the issues and then open it up to the floor for questions and comments and all sorts of different debates and discussions if you'd like to. If you disagree with something that's said, please feel free to push back, as long as, of course, you are respectful, as I expect everybody here will be. Thank you so much again for joining us, and I'll take my seat, and we'll get started. So I don't know exactly how we're going to get started, except to say a very broad question, which is, should Obamacare be repealed? Also known, of course, as the Affordable Care Act, passed in 2010. It was signed into law on March 23rd. Where are we going to be going from here? Is it something that should be repealed? And if so, another add-on question, should it be replaced? And let's start with Juliana.
So yes, the Affordable Care Act should be repealed, mostly because it is not providing its intent affordable care. So premiums have been skyrocketing, choice has decreased, a lot of insurers are leaving the individual market. 1 in 5 people only have one choice when it comes to an insurer, so that doesn't provide a lot of affordable options. The individual mandate is not working. A lot of people are choosing to pay the penalty instead of buying coverage that is too expensive for them. And pretty much on every metric, it's not doing what it's supposed to do.
Dr. Parr?
Yes, it should be repealed from the medical standpoint. It's interesting looking over the past 25 years of medicine about how medicine's really changed. In the last 8 years in particular, if those of you have actually now seeked any medical care, you realize that what you had before Obamacare and what you have now for coverage is very different. One of the things I think is self-evident here in Colorado is the fact that, individuals, young people that are seeking entrance to Obamacare have noted that there's huge differences about, for example, the catastrophic coverage you used to be able to get here in the state. For example, you could get $60 policy that covered you if you got hit by a car, if you got cancer, but those things went away. The mandates of Obamacare changed medicine as how we know it. Pre-existing conditions, for example, that's changed as well too. But the issue is healthcare is more expensive now. The deductible issue that's happened in the United States has hit physicians' offices dramatically because in order for us to see you, we have to meet your deductible. Through Obamacare, for a single individual, that could be as high as $6,250 a year. That is astronomical. The great majority of people in the United States that are young don't have that kind of money. They just don't. So you have to literally get run over by a train to even actually get into that cost. So there's an access really to medical care that it's been affected. There's also an issue regarding hospitals and providers and networks. Obamacare provided the insurance companies the capability of going back to the networks that we had in the 1990s. At that time here in Colorado, we had about 15 independent physician associations associated with pods or networks within the system, where if you had Cigna, you could go to Swedish, or if you had Pacific Care, you could go to Porter, but you couldn't go to the opposite hospital 10 blocks away. It's gotten back to those days again. And also the networks where you could actually go to a certain pod of physicians, but you couldn't go to specialists outside your pod, or you can go to the University of Colorado. Within Obamacare, and Andy and I were discussing this a little while ago about the fact that within Obamacare, if you have especially needs regarding cancer, within some of the policies, you can't go to the University of Colorado, even though they are a cancer specialty clinic that's designated by the NCI, the National Cancer Institute. So because of the fact they don't recognize them as being part of their network. So it's a limitation of care, it's a limitation of providers, a limitation of choice for the consumers, and that affects medicine. So as physicians, we are now relegated within that particular system, and we need to change. There needs to be better choice for consumers within medicine.
Now, Charlie Katibi, I want to ask you about the question of repeal, but I'd like you to talk a little bit about your personal story as well, because we have an interesting thing in common in that we are both violating the law, and we're admitting it today. which is that we do not have health insurance.
We're illegals, you might say. Yeah.
That's a very fair way of putting it. So we are not complying with the so-called individual mandate. Talk to us a little bit about your personal story and why you think Obamacare, I presume you think, should be repealed.
Yeah, sure. So I'm a relatively healthy person. I don't need very extensive medical care. But like just about everyone else here, everyone has a fair shot of getting run over by a bus or a car. I would like an insurance policy that would pay for that unforeseen event. But because Obamacare large, every insurance policy with a bunch of really expensive mandates on what it has to cover, it simply makes no sense for me to be able to pay for it. In the state where I live right now, Wyoming, the deductibles are around $7,000, and it costs around $4,000 just in premiums annually to pay. And that's a big reason why people like you and me, young people, are not buying this coverage and why it makes no sense for us.
Now, there, of course, is this promise for those who are under age 26 at least, that they will be able to stay on their parents' health insurance plans. And I wonder if you could speak to that for a moment, Charlie, because when we talk about the idea of putting somebody, or keeping somebody on their parents' plan, it seems like a great idea. It seems like it's going to be something that will help the young people to maintain coverage, but are there any downsides to that, and is there a guarantee of coverage?
Well, there's definitely benefits for the people that are receiving the coverage, namely the young people. But there's also costs to that. If you mandate that insurers cover more people, that is more costs that are going to have to be paid by somebody. That somebody is usually the employer, which is how most people get their insurance. And employers don't just absorb the costs; they pass them on. They pass them on in the course of raising prices on their goods and services, but they also pass those costs on by not raising wages or decreasing the wages of their employees. There was a big study in a big journal that said that the annual salaries of everyone, the average salary has gone down by $1,200 a year because of that one mandate in the ACA. So it does have benefits, but we need to be very honest about how we pay for those.
Juliana, I want to talk about an issue that actually Secretary of Health and Human Services Tom Price brought up on Sunday when he made an appearance on Meet the Press, which is whether or not coverage equals access to care. That if you have, say, coverage under age 26, or you're somebody who is older than 26, and you have health insurance coverage, whether or not that actually equates to access, that you actually are able to see your doctor and get care.
Yeah, and that's a great point because that's what a lot of people point out when we talk about the Affordable Care Act. The uninsured rate has definitely decreased, but coverage does not mean care. Small networks are networks that have very limited choices when it comes to things like specialists and special labs and where you can get your MRIs. And those networks have actually, the number of small networks has decreased under the Affordable Care Act, so a lot of people don't have those options. And then especially when you think about Medicaid, which you already have a problem getting those people access to doctors because state budgets are so tight that they have to decrease wages for the doctors who see those patients. So patients already have a hard time accessing care under the normal Medicaid program. And then when you expand it to people above 138% of the poverty line, that those same doctors are forced to see a lot more people, and that decreases access. There's lines, and that's what makes people go to the emergency room, which drives up costs.
So in terms of millennials and whether or not they have benefited from the Affordable Care Act, Juliana, what do the numbers show as far as particularly young people signing up for health insurance coverage under the Affordable Care Act? And then also broadly speaking, let's broaden it to the cross-generational aspect, which is the overall numbers of whether or not it's really introduced more people into the insurance market and given them more access.
So the Congressional Budget Office, which I'm sure everyone has heard this week in the news, actually predicted that there would be 21 million people enrolled on the individual market this past year, and really in reality it was closer to 10 million. The uninsured rate for 18 to 34-year-olds is about 5% higher than the rest, mostly probably due to those high costs that young people don't want to pay. And millennials, our age, are 40% of the eligible individual market. In reality, they're 28%. So they're not getting the numbers they need to have an effective risk pool with young and healthy people to balance out the young, older, and sicker generation.
Dr. Parr, what is your sort of perspective, particularly as a physician, on why those numbers aren't necessarily adding up the way that has been projected in terms of, for example, the CBO, as Juliana pointed out, projecting in 2010 that by 2016, or in the year 2016, there would be about 21 million people that would sign up, and we didn't see that. We saw just over 10 million in 2016, and we're obviously seeing similar expectations not being met with regards to millennials. So talk to us for a moment about that.
I think the law was poorly designed. If you're looking at Obamacare and looked at how Obamacare is supposed to be funded, they needed more young invincibles. So the population of patients I like to call that are the millennials are healthy as horses. They needed a lot of millennials to enroll into healthcare insurance that they didn't necessarily need. So unfortunately for the advocates of Obamacare, the millennials are a pretty smart population. They figured that out pretty quickly, that the penalty they had wasn't very much. For example, the two illegals I have off to my side were able to figure out that they could pay the penalty, and it wasn't that big a deal. It wasn't a huge hit to their pocketbook. So my own millennial son, after age 26, he was uninsured for about a year, and it really bothered me. And I told him, you know what, we need to get you insured. And he said, Dad, I'm healthy as a horse. I'm 10 times healthier than you. I can outrun you. I'm a lot, I don't have any major issues. I'm not on any medications. I'm willing to wait for another year until I get married and then go on my wife's insurance. Why should I not? And he had a legitimate point. So the law is actually was designed so that it was an onerous enough obligation for the millennials, for the young invincibles, to enroll, to feed the premiums into the major insurance companies like UnitedHealthcare, Blue Cross Blue Shield, Aetna, Humana, so that they could then fund the people that did get into Obamacare, which is the people with a lot of chronic medical problems. For example, before Obamacare, there were pre-existing medical conditions that the insurance companies actually deemed people on. So if you had, COPD, chronic obstructive pulmonary disease, coronary artery disease, diabetes, hypertension, multiple chronic problems, they would basically grade you on that level and actually grade your premiums and what it was going to cost because they're pre-existing conditions. Obamacare took that away. So everybody that was really sick through Obamacare that had multiple pre-existing conditions, Obamacare is a great deal, okay, because those guys are coming back from the hospital all the time. Remember, these are not Medicare patients. These are people that are less in age Medicare patients. So more people enrolled that were sick chronically than more people that enrolled that were healthy, the young invincibles, and that caused the start of the death spiral. So as we all know, insurers like UnitedHealthcare, Blue Cross Blue Shield, Humana, Aetna, they've all started making choices because their loss ratios were incredible the first couple of years of Obamacare. And what happened was, it was written within the bill that there was a reinsurance that they could actually get back their costs of their losses, which were in the billions of dollars, by the way, the first couple of years. So they got back that money from the federal government, but there was no money actually designed from certain sections of the federal government to where they're going to get it. And President Obama got it from somewhere. No one knows actually where he got it from. But after that, there was a change to the law, and they had a revenue neutral law where he couldn't get it. So right after that, mysteriously, UnitedHealthcare announces, as we all know, is dropping out of several exchanges to the United States, and then others started following the death spiral. Mm-hmm. So as we know, there's certain counties like Charlie's talked about in Wyoming that don't have a lot of choice anymore. They only have like one insurer in several counties, including areas of the United States. So we're talking about the process of the law that was designed with a certain intent, but actually turned out very differently.
Mm-hmm. Charlie, I want to bring you back into the conversation, particularly thinking about the different mandates. Obviously, we talked about the pre-existing conditions mandate, the individual mandate, the 26-year-old so-called millennial mandate. But what I'm seeing in addition are a number of different regulations and mandates that have really stimulated, at least the argument goes, costs to rise because of these regulations that are seen as burdensome or mandates that are seen as burdensome. Is that an accurate argument? And if so, what are a couple of the mandates that are particularly causing skyrocketing costs of care?
So these are the mandates the Obama administration and Democrats never talk about. They talk about the great ones, the ones that sound great, the ones that keep children on their Parents plan until they're 26, protects people with pre-existing conditions. There's one that simply just raises costs on millennials to theoretically lower costs for older people, and that's it. And it's called age rating restrictions. Normally, in a normal market for health insurance, you would charge people based on their risk. So if a drunk driver approached a car insurance company, they would be charged a higher risk versus somebody with a clean driving record. It's the same in health insurance under a normal system. Younger people would be charged a lower premium, and sicker people and older people would be charged a higher premium. And that's how it needs to work. You need people that are going to be using it less to be charged less so they can pay into the system. What the ACA did is they said they limited how much, it's basically like a minimum wage for health insurance premiums. Normally, a health insurance company would charge a young person a fifth of what they charge an older person because that's how their costs are reflected. What the ACA said is you can only charge them as little as a third, a third, which nearly doubles the premiums. That one rule nearly doubles premiums for young people. And the Manhattan Policy Center, Manhattan Institute, actually did a study which looked at the premiums of young women and young men. And they found that in the first year that the ACA went into effect, the premiums for young men doubled, and the premiums for young women went up by 50 to 60%. That's not how markets usually operate. They don't have those massive swings. Everyone knows those regulations led to that effect.
And then something else that is included in the Affordable Care Act, and also would be kept in the American Health Care Act, which we'll talk about, is the concept of essential health benefits. These also provide for additional costs, especially for people who may not need particular types of coverage, Charlie.
Yeah, that's right. I mentioned these before. Every health insurance plan, a family plan, whether it's a female or a male, every plan must cover pediatric care. They must cover a range of preventive services. They must cover substance abuse treatment.
Mammograms, colonoscopies.
Everything. It doesn't matter what your age is, what your gender is, or if you're a Quaker who doesn't drink and will never probably need substance abuse treatments. You have to buy those things, which also drive up the cost, and which is also definitely another factor.
Yeah, I'm so struck by the cost mechanisms just from my own personal perspective. I'll just chime in. This aspect is that, as I noted, there's a 26-year-old mandate. I don't have health insurance. I'm 26, so I'm above that anyway, where I couldn't be on a parent's plan. But I have a brother who's 24 and a sister who's going to be 20 at the end of the month. My parents both have health insurance. My dad recently switched jobs to become a small business owner. And when he did that, he entered onto an entirely different mechanism for getting health insurance. So he looked at the plans to figure out what he could do for my sister and for my brother to be on a family plan, and found that it would have been an $8,000 premium in the year for the four of them, and would have been a $12,000 deductible, making absolutely no sense for them to be able to move forward with something like that, because it's just not affordable. It's just not practical to reach that type of a deductible in that circumstance. And so now, my parents both have an insurance plan with a high premium, high deductible. It's as though they don't have insurance, my dad says. And then my sister goes to School of Mines. She has very good quality coverage through the college. But my brother, 24, doesn't have health insurance. So here you've got two young people who are under age 26 who, because of the costs of affording insurance coverage and also being able to get access to care through the cost of deductibles and so forth, my sister would not be with insurance, most likely, if she wasn't going to school right now and didn't have good coverage there. My brother without, despite the 26-year-old mandate. And that goes to the fact that you have all these things that are increasing costs substantially. And so I want to go back to Juliana in regards to what is the fundamental crux of why these costs are so high and how they can be adjusted and addressed through reforms. I mean, when we repeal Obamacare, if that happens, what types of reforms can help address the fundamental problems that have stimulated this rise in costs?
Yeah, so the fundamental reason why costs are so high in healthcare is because there's no pricing. There's very few other industries where that is the case. So when people don't have prices to shop around and compare for deals in the higher quality services, then costs go up for everyone. So the new bill has several free market-based approaches that should, in theory, make costs go down if they're paired with decreasing regulations. So things like expanding health savings accounts, which gives people more control over their own healthcare costs because they can put their savings away, tax deductible, and then use those things for out-of-pocket expenses. And studies have shown that when people use their own money for things like co-pays and deductibles, they choose services that are the best quality at the lowest price. And if enough people do that, prices go down for everyone, even people that don't have health savings accounts.
Dr. Parr, pricing is something that you've talked about as well, particularly in the practice of medicine and how that looks. Expand on what Juliana was just sharing.
I can talk about from the small business employer perspective, and then I can talk about the physician perspective. But I was sitting here thinking about some of the things we just talked about a few seconds ago. So before my practice was sold in 2012, I had 32 employees. I elected, because I could do it in those days, to get a low deductible, low premium program, okay, which was the best of the best. And I got that for my family, for my employees. So for 32 people, including family members, we are paying $234,000 a year for insurance for that cost. Now, that's the premium program that you can possibly get. To do that now in the year 2017 would be astronomical. It would literally double that cost because the Affordable Care Act made that kind of insurance horribly expensive. So it priced it out of existence, basically. It's more common now for employers to get the higher premium, the lower premium, higher deductible plans because it's more economical for the employees to do so. So it's a pure economics plan. But as far as like the medicine costs, if those of you who have been in the hospital and look at your medical bills, you've seen that hospitals have an enormous capability of charging very large amounts to the Affordable Care Act. And the American Hospital Association did sign for Obamacare, by the way. They thought it was a good idea. So hospital costs have increased over the past 8 years. But the funny thing is that you can have hospitals, for example, where two hospitals are literally located 10 blocks away from each other here in the city, and you will not know the cost structure. I mean, you just won't know how much one hospital costs versus another. To have that information as a consumer, it may make a difference if you decide if you want to go deliver your baby at, Skyridge versus Littleton Hospital. So there is a difference, trust me, a big difference of those who deliver babies there. So we need to have that available to the community so that as healthcare consumers, you can make your choice regarding where you want to go. If you had that information, would it make a difference in your choices? Of course it would. Is that available locally? No. Is that available nationally? No, it's not. Okay, should it be? In a free market society, we should have that available. And would that actually then allow Hospital X to compete with Hospital Y and then adjust their prices appropriately so that the level of care you get inside the hospital would be more in measure to what you'd expect? I mean, if you look at the hospital bills, it's not uncommon for a tablet of Tylenol to cost you $15. Okay, so, and they do it all the time. So if you don't believe me, just go in there for appendicitis. Not that you should, but if you did, you're going to find out that's about $25,000 on the average, of which there's a lot of charges tacked onto there. Or if you went to that hospital and said, hey, I want to pay cash, they will negotiate for you for 20% of that amount, okay, if you pay cash. So there's a difference right there in the level of care and the level of cost. And we need to have that more in the open. UnitedHealthcare actually rates hospitals within the state, but they don't let out the data very easily at all. I'd highly recommend you go to their website and look at the differences between hospital costs within the city. You'd be highly surprised which is the most expensive hospital within the state.
Charlie Katibi, I want to ask you about some of the key principles of reform. So obviously we are seeing the American Healthcare Act just put forward to the American people a couple of weeks ago. And there's a heated debate, not just among Democrats and Republicans, but also among Republicans themselves over whether or not this is the right route to go. Yeah. In your mind, what are some of the key principles of reform that really should be included in order to, say, inject choice and competition into the marketplace, in order to get pricing back into the system so that you actually have that taking place, and in order to make sort of an equal playing field for all the different players in the system?
The biggest thing is putting patients in control of their healthcare and letting them control their healthcare dollars. As Juliana said, when people control their money, they care how much is spent. And hospitals and providers will start. It's not like they can't provide the information, the prices of those benefits, but we need to demand them as consumers. And right now, we have no incentive to do that. Most people are covered under Medicare and Medicaid. They have very little. They demand very little deductibles or copays from their beneficiaries, so they don't care about the price. Another 170 million people are covered by their employer. That covers most of their premiums and a good portion of their deductibles. They don't care how much it costs. So if we want reform, we need to let people control those dollars so they'll have an incentive to save those dollars. And health savings accounts is a great idea, and the American Health Care Act has included those. So that is definitely a good start.
What else in the American Health Care Act strikes you as being positive, as potentially being at least components of what a successful reform legislation, a replacement bill, should include?
So one of the biggest reasons why Medicaid's costs have exploded, especially for states that have expanded Medicaid, is that the beneficiaries have no reason to care how much it costs. And a big reason why is because when states ask the federal government for permission to levy small little fees, tiny fees, because these are very low income people, tiny fees on the beneficiaries, so they care how much their benefits cost, the federal government says no. What the American Health Care Act, though, says is they will give states a lot more flexibility to tailor and control the program. So states will start being able to levy small copays and tiny deductibles on those beneficiaries, so they care about how much they're spending, and they have an incentive to control their personal costs. So that is a really great place as well.
One of the interesting things, Juliana, is the fact that this isn't just one bill that Congress is looking at as a possible single hit solution. There's actually a three-step process, a three-phase process that would be entailed in this direction that they're headed in. Why is there a three-step process, and what does that entail?
So in order to pass a bill, as we all know, you need the majority of votes, but you also need to be able to prevent a filibuster. So they have this thing called the reconciliation process. It's actually how the original ACA was passed also. So when you use this process, you only need 51 votes in the Senate. So that's how they're going about passing this new law. Because of this, the only thing that it can affect are budgetary outlays, so it can only affect the total deficit and direct spending. So because of that, they're very limited on the regulatory changes they can make. So they can't do a lot with essential health benefits, for example, because those are industry regulations. But they can do things like say that the mandate for not buying insurance is now $0, because that has to do with money. And they can reform Medicaid, because that's all federal and state spending. Ideally, they get to step 3. Step 2 is regulatory, done through Health and Human Services, making regulatory changes through a comment and rule period that is separate from Congress. But then the plan would be eventually to get to step 3, where they can pass additional reforms, hopefully with bipartisan support, that make additional changes to make the industry more free market oriented. So they could do things like association health plans. They could hopefully cap the employer exclusion, things like
And
that.
let's dissect a few of those things, starting with the employer exclusion. I mean, this is something that a lot of people don't really know about how it's set up, and it's something that really, Juliana, goes back to the 1930s, 1940s during World War II.
So it used to be that you would pay for most of your healthcare costs out of pocket and have insurance for insurable events, which mean events that you don't know are going to happen. That's really what insurance is supposed to be for. During World War II, they instituted a wage freeze to help combat inflation, but they exempted employers from they exempted employer health benefits from those taxes. So they could offer extensive benefit packages to their employees without being taxed. So because of that, we set up this employer-based insurance system that is now dependent on where you work and not where it's not portable at all. So ideally, your insurance should go with you wherever you go. If you change jobs, that's great. If you retire, that's fine. But instead, you're tied to your employee benefits. Because of this, people who get insurance through their employer have a very big tax advantage to people who buy their insurance on the individual market. The new act attempts to remedy this by providing tax credits to kind of even the playing field as far as taxing both people evenly. What it does leave out, though, is this cap on the exclusion. So the idea behind this is to tax benefits at a certain level, say 90%, and that brings in revenue to the government to help pay for helping people afford care, but also disincentivizes people from overusing healthcare because they have unlimited options with no incentive to not overuse their care.
I want to piggyback on something you just said and go to Charlie on this point, and then we'll bring Dr. Parra back into the conversation, and that is tax credits. What are tax credits, and in particular, how does the AHCA, the American Health Care Act, address that, particularly in terms of the so-called refundable tax credits? I mean, this is a term that's thrown about. A lot of people not very clear on what the term refundable means, but what is a tax credit and what is a refundable tax credit?
Okay, so a tax credit is basically a subsidy that people get, but you first get it in the form of a lower tax liability. So if there's a $2,000 tax credit and you have a $3,000 and you owe $3,000 in taxes, you will only have to pay $1,000. That's how they work. But if you're a low-income person, you don't just get a lower tax liability because low-income people don't really pay much in taxes just given their income. They get a check in the mail. And this is the biggest sticking point among conservatives over how to not just repeal it, but replace the ACA. Because there are 20 million people right now that are either on Medicaid expansion or receiving subsidies on the Obamacare exchanges. If you just repeal the ACA, those people, most of them, will not have insurance because the subsidies will go away and they simply couldn't afford it. So the big debate right now is, do you allow low-income people to receive some sort of subsidy, not the ACA subsidy, but some sort of fixed subsidy that they can receive and help them pay for insurance? And a lot of conservatives hate this idea. They call it an entitlement because it's a government program that spends money. So the big sticking point is for anyone that hates the ACA and wants to repeal it with something more market-centered, more free market is, are you okay with giving low-income people money to pay for insurance? That is a major issue. That is a major debate happening right now.
Dr. Parra, what is your take on the idea of providing tax credits to help enable people to make a health insurance purchase, particularly those who are on the lower income spectrum and might be otherwise in need of assistance in order to afford any sort of plan?
Technically speaking, getting subsidies right now through the ACA is technically an entitlement, technically. So what they're doing is actually changing the law around. I think we'd probably agree on that. The question is, once you actually do an entitlement, like the tax credits you Charlie just described, it doesn't ever really go away. So there is major issues. He's right that, I mean, from the conservative standpoint, there's a lot of discussion about this, about creating another entitlement. So it's being bandied about quite a bit for Congress, and I honestly do not know where that's going to go. Do I think they need to take care of the people that are being subsidized because they cannot lose insurance? You have to be able to get health care. So you have to have health care. Do you have to have the same kind of insurance that Obamacare provides? No, we got to transition to something else. That's my thought. The question is how to do it. How's that transition going to be? I'm ambivalent about it, to tell you the truth, because there are some people in our society that need to be helped. Okay, so not a lot, but some. And the great majority of people in the United States have employer-based health insurance. They don't need that assistance. There's a significant part of people on Obamacare that do. And, one of the other things I was thinking about, just to go ahead and add something else that we've not talked about very much, that's not part of the reconciliation process right now, is interstate portability. Physicians have very strong feelings about that. So let's say that you're traveling in Nebraska, okay, and you get run over by a train. Okay, you have out-of-network benefits for your insurance with Blue Cross Blue Shield of Colorado, where if you get run over by a train, they'll take care of you in the emergency room in Omaha, Nebraska. Okay, if you try to go in there and try to get your, high blood pressure evaluated, unless it's emergent, you will have no benefits. You cannot get routine care out of state. So one of the things that's interesting is the interstate portability is not being talked about currently at this point within reconciliation, and correct me if I'm wrong, Juliana, because they can't do that. I mean, that's not part of reconciliation, but that has to be part of probably part 3 in the future. We have to be able to have free market values within medicine where you can actually then have Blue Cross Blue Shield of Nebraska and Blue Cross Blue Shield of Colorado. And then as a consumer, you can be able to pick one versus the other and still get care. So that if you got Blue Cross Blue Shield of Nebraska, you can still stay in Colorado because it's cheaper insurance, it's better benefits, you'll shop around. What is going to be the market forces when that happens? They will actually start leveling themselves out. Where the expensive one for Blue Cross Blue Shield of Colorado, for example, may say, hey, we're too expensive versus Nebraska, let's do this. So there are free market forces that do not occur within medical care at this time.
Just a couple of final points or questions, and then I want to open up to the floor for any audience questions that you may have. And that is in regards to this idea of leveling the playing field and bringing out competition. I think it's so important. We've talked about this before, the four of us. It's so important to really understand that with the absence of pricing, with the absence of direct payments from so many consumers, with all the advantages that big businesses get that individuals don't get if they're going to be on the insurance marketplace for themselves or for their families or for their small businesses, there are so many different things that have made this an environment where there is such limited choice and limited competition. In fact, Charlie, I know in your story in Wyoming, there's Blue Cross and Blue Cross Blue Shield, and that's the health insurance company that you were able to look up for the possibility of getting a health insurance plan. Just one company. That's staggering to think about. But I look at it as a millennial from the perspective of somebody whose generation is so commonly using such apps and ride-sharing services as Uber and Lyft instead of taxis. I mean, remember the days of always picking a taxi and having to maybe deal with a rude taxi driver or a dirty seat, in the back seat or something like that. That has changed very much with the competition that has been exerted by Uber, Lyft, and other ride-sharing programs. You look at New York City, you look at DC, and how those systems of taxis have really been cleaned up. Taxi cabs have really been cleaned up over the years as a result of these ride-sharing programs because they've injected competition in a place that just wasn't there. There wasn't this kind of price competition before. There wasn't choice before, and now you get it. At least if you have an Uber or Lyft in your location. For example, in my hometown of Albany, New York, Uber and Lyft are not legal. They're not allowed in that region, in the capital region of New York State. And so there's not that same level of competition and choice. But I really think if you can bring it home in understanding, especially for millennials, that if we were to just bring a set of choices and competition and level the playing field so that everybody could be able to have an equal shot at getting affordable health insurance and access to care, very much like the system of ride-sharing apps or choosing a taxi, which now taxis have apps and so forth, you'd really see some vast improvements in terms of quality and cost affordability down the line. And so the key question that we asked ourselves as a group in developing the policy paper that we're going to be publishing this evening is about how exactly we can use health savings accounts, use tax credits, use these different tools and resources that are at the disposal of a market-based system to really inject opportunity and choice and competition into the marketplace. And we did come up with a particular idea or set of ideas that could approach that, coupled with some other aspects like association health plans, as you mentioned those, Julianne. I'd like to delve into what those are a little bit. But what is it that we were looking at to really examine how we can bring in choice and competition in a way that might set up a system more like the system that we see with Uber, Lyft, and taxis? Whoever wants to kind of tackle that first.
I can go. So health savings accounts is a big thing, but we really were thinking even beyond just how they work right now. So even though a lot of people, about 17 million people, use health savings accounts, there are a lot of restrictions on what you can do with them. You can't use them on over-the-counter medication. You can't spend them on health insurance premiums. You can't, and there are even restrictions on what kind of out-of-pocket spending. For instance, if you wanted, there's a new system out there where physicians don't even accept insurance. They just accept a monthly payment, like sort of like a gym membership for direct primary care. And then that's how that's provided. That's a very cost-effective system because the only reimbursement they're getting is that monthly reimbursement for each patient. However, you cannot spend health savings account contributions on that. There are a lot of ways we can expand health savings accounts, and one way to expand them to lower income people is first to open them up, and then to provide a refundable tax credit right in there, so that low income people will have that access to get health coverage.
But
and
why
healthcare.
into a HSA? Why not just to pay for premium?
So a big reason why a lot of free market conservatives don't like just giving a refundable tax credit to buy health coverage is that in the future, there might be liberals and Democrats in power, hypothetically, that might say, if you want to receive that refundable tax credit, you have to buy an Obamacare-like health insurance plan. So it keeps the door open for those insurance mandates which drive up the cost. And don't actually help the patient. However, if you give it straight to directly to an individual to that health savings account, that short circuits the political process that would usually say that health insurance policy must cover abortions, it must cover birth control, all these other things that some people might find controversial. So that's one way. It goes directly to them, and it depoliticizes those benefits.
So they would be able to essentially purchase a health insurance plan if they wanted, catastrophic, having all sorts of essential benefits if they want them.
Mm-hmm.
They could use them for over-the-counter medicine. They could decide not to get insurance and instead to just build up a nest egg if they're healthy millennials, that kind of thing.
Yeah, I mean, the ACA sort of poisoned the entire debate by assuming that there was a one-size-fits-all health insurance plan for everybody. There are some healthy people that just need a catastrophic plan. There are some people that do need more comprehensive coverage, but it should be up to them to decide. Absolutely.
Juliana, if you want to piggyback on that and add anything to the conversation about the health savings accounts and expanding those in such a way, but also talk about as kind of a final piece here of something that is also being discussed for phase 3 of the American Healthcare Act that's been proposed, is the idea of AHPs.
Yeah, so the great thing about tax credits, especially in health savings account, is they can help everyone, rich and poor. So it would be a great way to help people graduate off the Medicaid system. Right now, there's this thing called the Medicaid cliff. So you have all of these benefits, but as soon as you reach this level, your benefits are taken away, which really disincentivizes people from leaving the program and traps them in poverty, which no one wants. We want people to be successful, thriving on their own, self-sufficient. So if you can graduate those tax credits based on income, it allows people an easy transition off the government system to be able to then purchase more extensive benefits if they like or whatever they need for that area of their life. As far as association health plans, those work by bringing negotiating power to smaller businesses. So the only way prices are driven down is if there's a big enough market demanding it. So if things like churches could band together or small businesses could band together and have their own risk pool with all of their individuals, the insurance companies would be more willing to negotiate with a large group of people as opposed to just one single business owner. So it brings down costs.
Dr. Parr, any final thoughts from you before we open up to questions?
From the medical standpoint, HSAs make sense. The current law right now, which President Obama changed some time ago, was that before, as you probably know, for those that have HSAs or FSA accounts, you can actually carry them over the next year. You can't do that anymore. Okay, the great majority of the accounts now, you can carry over $1,000 if the companies you work for let you do it, but the great majorities don't. So one never plans on getting run over by a train, as I've talked about, or one never plans about having cholecystitis and get your gallbladder taken out, or having your appendix taken out emergently. So having HSAs planned for medical events in the future by carrying over allows basically as a health savings accounts for the future. So why not consider having HSAs fund you for that event in the future that you don't plan? You know, for example, having acute leukemia or having lymphoma or colon cancer. Those things happen, unfortunately. So that's what those funds should really be there, for those catastrophic events, really. Because at this point, the deductible plans, the high deductible plans of Obamacare is catastrophic insurance. That's basically what it is. I mean, for a family that's here on the Bronze program in Colorado, some of them are at $13,000 a year deductible for an entire family. That's a major catastrophe, and no one meets it. So having an HSA build for the future for medical expenses as an individual and family makes tons of sense from the medical standpoint.
Dr. Parr, remind me never to come within a mile of a train track with you anywhere near. And
It sounds absurdly
keep me-
common.
Yeah,
I had
exactly,
that
exactly. I think everybody's feeling the same
I had
way.
that happen to me once here in Colorado once. That's why it sticks in my mind. So,
All right, fair enough. So what I'd like to do is, if we have audience questions and comments, we'd love to get your take on this. Comments, questions, anything along those lines. We're happy to do it. Skinny's got the microphone. I don't know if we have.
I do.
Yeah, and if you wouldn't mind just doing it, or we can grab somebody from the audience who might be willing to.
I've got one question if I can start out, if that's okay.
Please, by all means. Skinny, by the way, has kindly donated the sound system for the services this evening. So thank you.
Happy to do it.
Skinny.
You mentioned that a lot of hospitals would give like an 80% discount. Is that what you said?
yeah, they do
Huge
it.
discounts.
Yeah,
And,
they do it.
That is very true. I got a 90% discount by paying cash for the birth of my 3 children. When I have a 20% copay and they give me a 90% discount if I pay cash, why would I ever have insurance?
Because the event, if you really do get hit by a train,
Right.
and it's a
So it's all-
$100,000 event.
It's all about
So-
catastrophic is the point, absolutely. But it's ridiculous. The prices are very difficult to find, but they are out there. It's like pulling teeth to actually get the price, which brings me to really a very short follow-up. I'm not for regulation. I'm a very small government fellow, but if it's an easy regulation and it makes sense, so what do you think about this? Just force health providers or hospitals or healthcare centers or whatever to post their charge masters. They all have a charge master. Why not just say post it? You have to post it online. That seems like a pretty easy regulation to just follow up with, and then it can be public, and then people can shop.
So,
Let me talk about one thing and I'll clear up what happens with physicians right away. So what you're talking about is the old days where doctors used to actually have, charges for X, Y, and Z within the office. Nowadays, physicians don't do that. So we are paid as a percent of Medicare for United Healthcare, Pacific Care, Blue Cross Blue Shield, Aetna, Humana. So we paid contracts, 130% of Medicare, 125% of Medicare. So we can charge $1 million per procedure. It won't make any difference. What we get for individual procedures, individual things we do in the office, it's fixed. Those prices have been out there for a long period of time. Our contracts may vary a little bit from state to state, but they're out there fixed, same as Medicare. You can do as much as you want to Medicare patient and try to charge as much as you want. They're going to reimburse you X amount. Same with the hospitals. Medicare reimburses hospitals a fixed charge. It doesn't make a difference if you have $100,000 worth of bill if their charge structure says they're going to pay you only $15,000. So what it makes a difference, though, is the commercial insurance, because remember, Obamacare is commercial insurance. So actually having those charges actually been made well known, and comparing hospital to hospital, urgent care center, outpatient surgical centers, that makes a difference, okay? Because I think you'll probably choose differently if you know that cost structure is different from place to place.
Can I piggyback off that? Yeah. There are charge masters. Every hospital has those prices. The thing is that it doesn't matter what the price is. It matters what people pay for them. Because each hospital has a bunch of different discounts for a bunch of different insurers. So I think a majority of states actually already have these government-funded websites that require hospitals and doctors to post their list prices. Colorado is actually one of them. They're very complex, and there's very little evidence that they reduce costs, that people actually care. And there was actually a survey of health insurance companies that actually made the prices available, but only 2% of people actually bothered to look. You can put those prices out there, but what matters is if people care about the price. And people will care about that if it comes out of their pocket and it gives them money. There is one way to do this, actually. There is a company called Smart Shopper that works with the State Employee Benefits Program in Kentucky and New Hampshire. And what they do is they let state employees go online and compare the prices across providers in their network for different services. The difference, though, is that if they pick the cheapest provider, they get a cut of the savings. And people use that a lot. And they save a lot of money with that program.
Real quick, Juliana, did you?
I mean, basically the same. So if me and Charlie both went and got our appendixes out, if we had different insurance plans, our pricing would be completely different. So that's why their charges vary so much. So it's important to bring the consumer back in with their own money.
Thank you very much. Skinny and,
Do you need my name?
actually, David behind you, Andy.
Well, thank you. Hey, Jimmy, great program. I find the facts and information very impressive and good to hear, and reinforce a lot of things that many of us already know. I find it amusing how Obama was to be the savior to the world and to the youth, and yet he really stuck it to them in price. And these facts and statements just make that point. I also find it tragic that somebody who in office now is trying to deal with this, and the hard part about it is how it's being seen as the boogeyman almost, to try to make the changes. And I'm coming to a question that may be more geared to you, Jimmy, because it's a media question. And when you try to deal with it, front page, 20 million people are going to be without insurance. The real issue isn't the insurance. The real issue is the subsidies being dealt with, how we deal with the money and how it's allocated. But you try to make a change, and you're a bad guy, and so forth. And so the question is, how do you get around from a media standpoint to look at what the real issues are? Is it subsidies? Is it we're out coverage? No, nobody's taking away your coverage. You're just not getting the subsidy that you really wanted, or subsidized by the young people, the invincibles, as it were. That's what the real issue is. How does that message get adjusted, Jimmy, nationally, statewide, and otherwise?
That's a very interesting question, just from a media perspective. And for those of you who don't know me, I host 2 radio programs in Denver, Monday through Friday program and a Saturday evening program. And one of the things that I find very interesting about what you were asking is that it really depends on the format of the media appearance. So, for example, if it is cable TV news, or if it's the half-hour, hour-long cable or network station news, or 60 Minutes or something like that, or if the format is a radio talk show, or a newspaper. It really depends on the format and what the host or the person who is doing the reporting or the commenting is willing to do in terms of the direction. So what I think is the best that I could really answer for that question, other than getting into a discussion of how I look at things personally, is to think about the Millennial Policy Center and how we might move forward with the conversations in the media, and being able to focus and narrow the discussion on particular areas, and saying, these are the things that need to be focused on. When somebody leads in one particular direction, pivot back to the main point, the key issue that is crucial, like the subsidies, or like the fact that there's not an equal playing field for individuals and small businesses compared with major multinational corporations and other large corporations. So I think it's really incumbent upon organizations like ours to try to direct that conversation when we have the opportunity. And then, of course, folks like myself in the media who are doing that on a regular basis to really be open to those types of questions. Andy.
Yeah, I'm wondering how we're going to get some of the Democrats to vote for the Republicans for any kind of change. That's, to me, the big challenge, because when the Democrats did it, they rammed it through without a Republican vote. And I think it's a mistake for the Republicans to ram this through without a Democrat vote. Is there any compromise? Because the great art of the deal, Trump, the idea is to bring maybe everyone into his office and hash it out. Is there a compromise situation you see where you can get some Democrats to sign on? Because I think that would make a big difference. Right now, they're posturing pretty clearly that they're going to fight against it, like they did with the confirmations for all the secretaries. It was almost party line. I watched them all on
Well,
TV.
the question is even more than that is, can you get compromise among Republicans?
Right, so I think that's the biggest question, right? So we have this supposed three-pronged system, so if we can do it only with Republican votes, figure out the regulations, then maybe Democrats will be on board once they see, okay, this is gonna lower costs like this. And another great thing they're gonna do is, Obamacare was this 1,000-page bill that covered, everything from medical school tax credits to like public health programs. So it's much harder to get buy-in on things like that. But if you can work on one specific bill that's gonna fix this one issue, then maybe you can get some votes. And so that's why it's so important to have this three-step system. I also have doubts that we're gonna ever get to step 3 because things are so completely partisan that they might not ever get Democrats on board.
We have another question.
First of all, great program, guys. Loving it, actually. So 2 questions. First and foremost is, how is the AHCA definitively better than the status quo? The second part of the question is, presumably upon the passage of the AHCA getting to phase 3, what does the world look like, both from a consumer perspective as well as from a healthcare industry perspective?
Good questions. Who wants to tackle that?
So I think the AHCA is a step in the right direction. I think it leaves a lot to be desired as far as complete free market reforms. But I trust, Paul Ryan and the other people in the House who realize ideology is great, but you have to be practical. And I think that they know their limitations, and this is what they're trying to get through right now. We all have to remember that no matter how great the bill is, there's going to be a lot of disruption in the market over the next few years. So prices might temporarily increase. You might lose your doctor, just like you did with Obamacare. Our system is so completely messed up that no matter what you do, there's going to be some balance that is needed. So I think it's important to be patient and look forward a couple years. And if you even look at the CBO projections that came out, prices and premiums decrease eventually, but if the first couple of years, they're actually going to go up, because once people that are forced by insurance choose not to, there's going to be a temporary effect from that.
We've had discussion among the 4 of us about what's going to happen, and the truth is that probably the AHCA will probably be in a different configuration when it finally gets to phase 3. And what's occurring right now, they're going to be modifying along the way. Just like Juliana said, they have to compromise, really. And I know that there's questions about whether Speaker Ryan's proposal will even get through a lot of the committees that it's gotten through so far. So I think it's in constant flux. I mean, we're going to see it change. It's not going to be probably in its current configuration the exact same way as it is right now. There's probably going to be some amendments to it. There's well-known conservatives within the House of Representatives that basically said they're not going to vote for it in its current configuration. Forget about the Senate. They've already talked about there's at least probably 4 people in the Senate that said they're not going to vote for it either. So they're going to have to change it within the House. I think it's something that's going to be a moving target that we're going to have to watch.
Charlie?
When they say phase 3, that is the phase that Democrats can filibuster. It's not the reconciliation part that can only be passed through with a majority. You need at least 60 votes to block a Democratic filibuster to do a lot of the great things we've been talking about, like selling insurance across state lines or letting churches and charities pool through association health plans. And Democrats have a huge incentive to block those, because healthcare is now on the Republicans' dish. And if they don't fix this, it will be the Republicans' fault politically. And they love that, because if the health insurance market collapses, Democrats can come in with a bunch of horrifying healthcare proposals from the left. And then the whole process will start all over again.
So I do want to go to another question. We've got a couple more questions. Let's be, if we could please, as brief in the questions, and then I'll pass it along to 1, maybe 2 people on our panel to respond to that, so we can try to get a few in before we have to wrap up the program. Don.
Thank you, ladies and gentlemen. Both the ACA and the AHCA appear to be Rube Goldberg-like financing mechanisms. Rube Goldberg, y'all millennials might not have heard that term. You can Google it later. but very complex insurance financing mechanisms with scant attention to the underlying costs of the care we receive. HSAs, I think, are a great way to infuse a competitive market force to it. But Dr. Parr, what about things like defensive medicine and tort reform? That topic hasn't been addressed in 10 years. Are those sorts of things meaningful? Do they have potential? And if so, how can they be brought into the discussion?
That's an interesting point because nationally they have not been brought to any attention at all, not in any significant way. Colorado actually had tort reform done about 25 years ago. It's been, since that time that I know of, there's been at least half a dozen attempts by the Democratic legislatures here in the state to repeal that, and they've never been able to do it, thank God. But what that means is the fact that physicians have a certain liability within the state. Now, that means that physicians can get sued a certain amount and no more. Now, if you go to a place like, for example, Massachusetts, and if you're a neurosurgeon, for example, your malpractice rates in Massachusetts will be astronomical. They could be as much as $150,000 a year, just in malpractice rates alone for insurance. Here in Colorado, because we had tort reform, that limits that amount. So there's some thought that potentially that helps out regarding defensive medicine. In other words, doing unnecessary tests that you don't have to do. So, for example, do you have to have a CAT scan every single time you bring your 17-year-old in that fell down and hit their head playing soccer? No, you don't. Technically speaking, you don't. You see, there's certain criteria you can do it. However, they do it. Okay, so there is defensive medicine that's practiced in the United States, some more areas than others. And there's actually some evidence showing that defensive medicine is practiced in areas that do not have tort reform. So I think that, yes, it should be discussed. Yes, it should be national discussion. And that would be probably phase 3. And I would suspect that that would get shut down so quickly and so fast because they would not get 60 votes for that at all. As you know, that's not been a subject of discussion one little bit. Do I think it should be? Yes. As a physician, do I think it's good that we have tort reform in the state of Colorado? Yeah, because we can attract good physicians here. They don't leave our state. They leave Massachusetts to come to Colorado.
And I will just add that in Paul Ryan's Better Way plan, the plan that came out, that was released in June 2016, did emphasize tort reform. So hopefully that would be something that they would try to do in phase 3.
And there's an interesting debate that I would mention is whether or not the federal government actually has any role in the first place in tort reform and to what extent they do. So that will certainly be an interesting discussion as we at the Millennial Policy Center start to explore whether or not the federal government should be involved and in what way, if so. Next question.
So basically, whenever there's a healthcare proposal, there's a set of winners and there's a set of losers. I happen to be one of the losers when the Affordable Care Act came out. My insurance got dropped. I had to get my own insurance. It was more expensive, and my insurance went up 35% year over year from last year to this year. Who are the winners and who are the losers? Let's be frank, for the AHCA, because every proposal has them.
I can take this.
Please.
So, like I said, I think the current proposal does leave some things to be desired. So with Obamacare, yes, people like you were the losers. With this Republican plan, since the tax credits are age-based only, it's going to hurt people who are older and sicker and younger and sicker because you're only getting subsidized based on your age, which is the insurance model. That's how insurance works, and that makes sense in one way. I think the reason they're not doing means testing is because it increases health care cost inflation, so you can equate it to things like federal student loans. So when the government pays for people to go to college, tuition rates go up. So that's why they're hesitant to do it based on means testing, because I think it'll increase healthcare costs. But I do think there is an argument to be made that we should be means testing people at the lower end of the income spectrum and giving them additional credits based on their income so that they're not left without care. And the same could be said for people who are older and have really high healthcare costs.
And Charlie?
I will say this, there is one loser, and that's people that are currently on Medicaid, that went on through Medicaid expansion. Because if this law went into effect, the ACA, and they decided to earn above the income threshold, which is about $16,000, $17,000, they will be ineligible for Medicaid expansion, and then they will get a $2,000 tax credit if they're under the age of 30. That is a huge subsidy or benefit cut from going from Medicaid, which spends about $6,000 per beneficiary, to getting a $2,000 benefit. And that might actually discourage people from leaving Medicaid, and it might discourage them from taking promotions and taking higher paying jobs. So that's one big thing to keep in mind.
I'm wondering if there are any additional questions that we've got. Yes.
Hi. About 10 years ago, I worked with a health insurance brokerage in both individual and group insurance. And some of the mechanisms and the trends of that time that helped group insurance providers curb costs were health savings accounts and incentivizing healthy activities, the work pedometer programs, and in health insurance you can't really rate risk factors in the same way, but incentivizing those healthy things. I've heard in the AHCA a lot of talk about continuing to cover pre-existing conditions. All of these things sound great, but ultimately, isn't that what makes costs skyrocket for health insurance providers and de-incentivizes them to be competitive? How could this be a solution while that's still in effect?
Real quickly, Juliana.
Okay, so they attempt to deal with this they keep the ban just because it's politics and that's how it has to be, but they do make it better by doing what's called continuous coverage provisions as opposed to a mandate. So they incentivize people to buy coverage when they're healthy early in life, and then they can lock in their rates there for the rest of their life. So if you get cancer or something, you're not forced to pay for that cost because you've bought in at the beginning. This is better because it's not a mandate, it's not government forcing you to buy something, but it's incentivizing you to make healthy choices. It also helps the insurance companies because if they know people are going to stay with them their whole life, they can do things where they incentivize people to do primary care and wellness visits, and they have a full year picture of that person as opposed to like a 1 year snapshot, which is what you have with open enrollment each year, where they're forced to take everyone despite their health conditions.
I want to go to another question if we can. Go ahead. Or it look like. Do you have a question?
So you guys had said about how the ACA de-incentivizes small businesses because it has to provide a certain insurance for every employee. How exactly does the AHCA address this?
It repeals it. It repeals that mandate. Yeah.
Yeah, so right now, you have to provide government mandated benefits and insurance to anyone that works 30 hours or more for your company if you have 50 or more employees. So that means a lot of small businesses have to choose between hiring their 50th employee or growing or expanding and making a profit. So, and it also limits hiring because they don't want to hire full-time workers. Instead, they want to only hire part-time workers. So if you get rid of that mandate, they can do what's best for their company, hire people that they need, and then you can eventually get health insurance through them.
Any additional questions or comments from the audience? All right, well, I have one final question to kind of wrap things up, and we'll start with Dr. Parra. Where do you think things should go from here? It's a very broad question, and intentionally so, and I'm giving you 30 seconds to answer it.
And I just used 2. We need to change for our system. I mean, physicians know that our medical system right now, what we are able to provide and what we should provide, there's a huge gap. Okay, we've known about it for a long time. We should be more involved with those changes and helping to develop consumer choices so that consumers can make a difference in their own health care. I think that the AHCA is an attempt to try to head in that direction, and we'll have to wait and see where it goes. Our idea from the Millennial Policy Center is the fact that we think it's a good idea, and from the medical standpoint, I think it's a great idea too.
Charlie?
Where do we take it from here? I think we need to roll back the open-ended exclusion or the tax deduction that employers get, and give those tax benefits directly to people, either in the form of a deduction or, as I favor, a refundable tax credit, which will also allow low-income people to go into the individual market, get that care, but they also care about the price. That is how you get to a consumer-driven market, when people care about how much things cost.
Juliana, where do we go from here?
I would agree with all of that, and I would just add that we need to get pricing back into the equation so healthcare costs come down, because that helps everyone. And then there's less debate needed about how much the government needs to be involved as far as subsidies and tax credits, because care is affordable for more people, and it's a complete free market system with less government. And that also is beneficial politically when we change parties and we all go back and forth and change. If the government doesn't have to be involved and the system's working well, it can just stay apolitical and people just can get the care that they need.
Bottom line, if we can go ahead and have a system that begins with the AHCA as a starting point and we build upon that, is that a good way to go? Does it give us a foundation to really build something positive? Really quick answers. This is lightning round and then we're done.
Yes, absolutely.
Yes, as it transitions.
Yeah, I think things need to be added, but it's a great first step. We can't just repeal, we need to start replacing.
All right, very interesting conversations which will continue moving forward with the Millennial Policy Center. You'll see us in different capacities on the radio and in print, hopefully on television, actually definitely on television, and in some other avenues as well. And we look forward to engaging you all in what we decide to do moving forward in terms of additional projects, tax reform, and other things. But I want to thank our incredible panel, Juliana Darrow, Dr. Michael Parra, and Charlie Katibi. Absolutely excellent team to work with. I'm so thrilled about what we've got going on. And I strongly encourage you to go to our website, millennialpolicycenter.org. Tonight, we're going to be publishing our policy paper. Beginning of next week, we're going to be publishing a couple of videos that we recorded today that are really going to bring home succinctly why we need to repeal and replace Obamacare and kind of some of the overarching views on how we might want to achieve that through choice and competition. Thank you all so much for coming. We really appreciate it and look forward to seeing you again down the road. Have a great night.